A pleasure naman ako, sir. Good evening. I would like to thank the PAO and our subspecialty society, the Philippine Ophthalmic Pathology, for this opportunity to share with you a very short lecture. Um, I will use the presented case vignette to discuss two broad topics, namely small round cell tumors and immunohistochemistry. Okay. Um, Small round cell tumors are a group of highly aggressive malignant neoplasms. Okay? Characterized by their very small, or relatively small size. They're just usually slightly bigger or to twice the size of your red blood cells. So they are also monotonous, undifferentiated, with high nuclear to cytoplasmic ratio. Meaning if you look at the cell, it's almost filled up with the nucleus and that there's only a scant cytoplasm in it. And they also present with typical histologic patterns and immunohistochemical features. They are relatively more difficult to diagnose based on routine histopathology due to their undifferentiated or primitive morphologic character. In other words, magkakamukha sila, right? And they are based classified based on their round cell patterns, the size of the round cell, and the origin of the round cells. Okay. Now, if you can see that in this table that there are so many differential diagnoses when you say small round cell tumor. This one is according to their round cell pattern. Okay, so we have the diffuse pattern, and under these are your Ewing sarcoma, pinnet, etc. We have septate or lobulated round cell patterns, alveolar patterns, patterns with rosettes, and some patterns with hemangioperitomatous vascular patterns, and some with other components like your pseudoglands and your cartilage. We also classify them based on their round cell size. Now, I mentioned they're all small, but they're not fixed in terms of size. There's also a very narrow range of sizes wherein they are classified. And these are the small round cell tumors in the orbit. Okay, all of these examples that I mentioned have been reported in the orbit. And this is the classification based on their cell origin. They can be neurogenic from the mesenchyme, they can be hematolymphoid, and they can be from malignant soft tissues like your desmoplastic small round cell tumor or poorly differentiated synovial sarcoma. I'd like to mention that this list also involves the examples from distant sites, but they all can metastasize to the orbit. That's why I included them in this table. Now, this case was referred to me for evaluation after receiving the official histopathology report of small round cell tumor. So these were the tissues that were excised by Dr. Imperial, as you can see here. Right? And on microscopic description, it's a tissue that contains sheets of small, fairly uniform cells with nuclei that occasionally exhibit coarse chromatin pattern and surrounded by scanty amphophilic cytoplasm seen infiltrating adjacent skeletal muscle. So ang ibig sabihin lang neto, actually what I described earlier, there's a very large nucleus that occupies almost all of the cell with a very few cytoplasm. So let's examine the slide more closely. You can see here that there's variable compactness. Some areas are more dense than others. And like what Dr. Imperial said, it is unencapsulated. And there's really no capsule that encloses the tissue. Okay? So let's view it. The higher magnification, we see that the tissue is composed of monotonous, small round cell tumors. And tuldok-tuldok with a granulocytic cytoplasm. So if you can see this cell, it's almost everything is almost occupied by a dense of a nucleus. Okay, so these small round cell tumors remind you of your lymphocytes. You remember your histology. You're in first year, they look like your lymphocytes. Okay, so we signed out this case as an small round cell tumor, more of the atypical lymphoproliferative disorder, considering lymphoma versus pseudolymphoma. When you say pseudolymphoma, it could be metastatic for this case. Okay? And take note that we already ruled out an inflammatory process because of the absence of other histopathologic features of reactive inflammation, like the absence of other inflammatory cells like your neutrophils, your eosinophils. Wala siya, puro lymphocytes lang, parang ganun lang nakikita natin as small round cell tumors. And there's also the absence of germinal cell layers, which are more prominent in inflammatory cases. Okay, so having seen that, we cannot stop at the diagnosis of small round cell tumor. As you've seen in the table, there are so many conditions that fit the histopathologic description. And therefore, we need to go to immunohistochemistry in order to definitively diagnose the case. Okay, so immunohistochemistry is a lab method that uses antibodies to selectively identify the location of markers in cells in a tissue section. It is based on the principle that antibodies bind specifically to antigens in biologic tissues. Because these antibodies are linked to an enzyme or a fluorescent dye, the antibody-antigen interaction can be visualized. Okay. So let me illustrate this with a simple animation that I made. Okay. So let's say they have a normal cell with a lot of surface receptors. They are not antigenic since they are considered as self, right? So unless you're talking about autoimmune diseases or conditions. So when these cells undergo neoplastic changes, they produce tumor antigens like this one. Yeah. Yan yung tumor antigens or tumor markers. Okay? And these tumor antigens may be identified if we tag an antibody based on their specificity. Okay? So, for example, we don't know what type of cancer cell it is. So, we try to test it with some immunohistochemical stains in order to identify it. So, here, there will be a specific antigen-antibody interaction if it is indeed that type of tumor that we are thinking about. No? And then during the processing of immunohistochemical staining, we introduce a secondary antibody linked to an enzyme. So this is the enzyme. Okay? There. And you know that enzymes, they catalyze a substrate. So in the slide, we introduce a substrate, and if this substrate will be catalyzed by this enzyme, you will produce some chromogen or products on top of the cell of under investigation. Okay, so this will only happen if there's actually a tumor antigen present on the cell that interacted with the primary antigen. antigen. Kasi kung walang nag-bind dito, there will be no enzyme substrate interaction that will follow. And so you will see that this chromogen will stain the tissues and they will look like something like this. Hello?
Yeah, we can hear you,
I'm
Doctor.
sorry. Sir,
Yeah.
patayin ko muna yung ano ko kasi baka bumabagal ako. Yun. Ay, sorry. Pindot ako ng pindot kanina. So, let's just go back to the case. The slides actually will stain brown. No? It's in the previous slide. Okay, so going back to this case, we chose 3 immunostains to be our initial panel where hopefully we can diagnose the case. So here's the Ki67 stain. It is sometimes used as a marker for metastasis or metastatic tumors. So it turned out negative. As you can see, the tumor cells under investigation did not stain. Wala siya yung chromogen. No? And then, here. Okay. This is the mark CD3, an immunostain for T-cell lymphoma. Again, it turned out negative. Although marami ka rin nakikitang T-cells. No? But these ones, they are not the ones that we are investigating. Siya yung parang blue na yan. Yan yung talagang tumor na hinahanap natin. And so the last immunostain that requested was CD20. And you can see that it is heavily stained. There's a very high expressivity of CD20 on the tumor cells that are under investigation. So we can say that this is a positive CD20 stain. Okay, so they actually indicate a high expressivity of monoclonal B cells, right? So here's a composite photo of the original H&E. Now we have to check it with the original histopath and then compare the immunostains, no? So we can see the actual tumor cells under investigation. And we can see that Ki67 was negative, CD3 was also negative, but for CD3, it is positive. So here. Okay. So the final histopathologic diagnosis of was B-cell lymphoma, okay, based on the CD20 positivity. So immunohistochemistry is usually interpreted as a panel and not just one slide only. No? You should request more than one. And then it is very important to review them together with the original slide to identify the tumor cells under investigation. Okay. So I'd just like to mention that immunostaining is very expensive. If you will request so many stains immediately. So there should be judicious use of immunostains based on clinical and radiologic data or information that was given to you. So we always talk with the surgeons regarding this one. And so basically, I just gave you a very brief lecture on small round cell tumors and immunohistochemical staining. There are so many topics about them, so that may be discussed for another time. Okay, so thank you very much for your attention. I would like to turn you over to the discussion of the treatment options for the lymphoma that was just diagnosed. Thank you very much.